All right, picture this. You're in the hot seat. It's a high-stakes surgical exam, and your career could literally be on the line with this one case. Today, we're diving deep into fistula in ano. This is a condition where, let's be honest, one wrong move can change a patient's life forever. So to really get into it, I'm going to be your guide, playing both the toughest-nails examiner and the sharp-weighted candidate. Ready? Let's scrub in.
Okay, candidate, the clock is officially ticking. A 40-year-old man, recurrent pain, some discharge, go. And look, I don't just want the textbook answer. I want to see how you think. Show me your process. How do you even begin to unpack this one?
Right, examiner. My approach here is all about building a solid foundation from the ground up. So, first things first, a really detailed history. I'm going to dig deep into the classic symptoms. After that, it's on to a very, very careful physical examination.
So what I'm listening for in the history is that classic story, the intermittent pain, the itching, and some kind of drainage, whether it's mucoid or a bit bloody. Patients will often tell you about this cycle of swelling and discomfort that finally gets better when something pops and drains. The million-dollar question you have to ask is about any history of a perianal abscess. That's a huge clue. Then, on the exam, I'm looking for that telltale external opening, and if I'm lucky, I might feel a sort of cord-like structure under the skin, which is basically a roadmap of the fistula tract itself.
Okay, good start. You've painted a clear clinical picture, but that's just the beginning. How do you get to a definitive diagnosis? And even more critical, how are you going to define the anatomy? Because let's be clear, with fistulas, anatomy is absolutely everything.
Examiner, the #1 challenge here is mapping the fistula's exact path. It's like being a detective. And to do that, I'd start with a foundational, time-tested surgical principle to guide my hands during the examination.
And that principle is Goodsall's rule. It's just a fantastic starting point. It's a simple clinical rule that helps you predict the likely course of the fistula tract, all based on one thing, the location of that external opening.
This diagram here shows it perfectly. Just imagine drawing a line straight across the middle of the anus, horizontally. Now, if the external opening is posterior to that line, so in the back half, the tract is probably going to take a curved path towards the back midline. But if the opening is anterior, in the front half, it usually takes a straight, direct path inward. It's that simple. And this rule becomes my roadmap, especially when I'm doing the examination under anesthesia.
Okay, so once I've used Goodsall's rule to get a general idea of the path during an exam under anesthesia, the next step is absolutely critical. We have to classify the fistula. And what that really means is understanding its exact relationship to the sphincter muscles, both the internal and external ones. You can't plan a safe or effective surgery without knowing this.
And this is what we're talking about, based on what's called Park's classification. You can see the 4 main types here. A, intersphincteric, is the most common one. It just runs right there in the groove between the 2 sphincter muscles. B, transsphincteric, is also common, and it actually crosses through the external sphincter. Then you've got C and D, supra and extrasphincteric. These are much rarer and, frankly, a whole lot more complex to deal with. Nailing this classification is everything, because it dictates the entire surgical plan.
Excellent. Very logical. So you've got your diagnosis, you've classified the fistula. Now, for the main event, what's your management plan? Walk me through the fundamental principles you would never, ever violate.
Examiner, my entire management plan rests on 3 non-negotiable principles. First, you have to be 100% sure you've defined the anatomy. That's non-negotiable. Second, you have to make sure any sepsis or infection is resolved. Often, this means a staged approach, maybe starting with a draining seton, which is basically just a little silicone loop we put in to keep the tract open and draining so things can calm down before we do the final repair. And third, and this is the most important one, the absolute #1 priority is to preserve the patient's anal sphincter function. Preserve their continence. Everything, and I mean everything, comes second to that.
Very good. Let's drill down on that. Let's say your patient has a transsphincteric fistula, the one that goes through the muscle. Now compare the surgical options for me. I want you to focus specifically on that 3rd principle you just mentioned, preserving the sphincter.
Okay, so this really comes down to the classic trade-off, right? The balance between cure and continence. On one hand, you have the traditional fistulotomy. This is where you just lay the whole tract open. It works great. We're talking to over 90% success, but only for simple, low fistulas, where you're barely touching any sphincter muscle. If you try that on a transsphincteric fistula, you're running a huge risk of causing incontinence. On the other hand, you have something like the lift procedure, which was literally designed from the ground up to preserve the sphincter complex by going between the muscles to get to the tract.
So, given all that, for this specific case, a transsphincteric fistula in a 40-year-old man, there's no question in my mind. The ligation of intersphincteric fistula tract, or the lift procedure, is by far the superior choice. It lets me tackle the root problem, the fistula, while making sphincter protection the top priority.
And the lift procedure itself is actually quite elegant. The concept is pretty straightforward. First, I make an incision and enter the plane between the internal and external sphincters. From there, I can find and isolate the fistula tract. Then I ligate it, or tie it off, securely on both sides of where it passes through. Finally, I just divide the tract right between those ties. The end result? You've disconnected the internal and external openings of the fistula, all without having to cut through the main sphincter muscle.
All right, you've picked a procedure, you've walked me through the steps, we're almost there. But the surgery isn't the end of the story, is it? Let's talk about the final piece of the puzzle, post-op management, and, just as important, the consent process. What are the big pitfalls, the red flags you need to look out for?
And this next part is a big deal. It's not just about what you know surgically, it's about your professionalism and how you communicate. So tell me, what are the absolute must-discuss risks that you need to cover with this patient during the informed consent process?
Examiner, the consent conversation has to be incredibly thorough. I'd start with the general risks that come with any surgery, bleeding, infection, that sort of thing. But then I'd get very specific. I need to be crystal clear that there's a risk the fistula could come back. That's a possibility with any technique. And then, the most important point of all, I have to explicitly talk about the risk of injury to the sphincter muscles. I'd explain that this could lead to issues with continence, which could be temporary or, in a worst-case scenario, permanent. I'd also mention the small risk of anal stenosis, which is a narrowing from scar tissue.
Excellent. That was a thorough, well-structured, and most importantly, a safe answer. You've clearly shown you understand the pathology, the anatomy, and the core surgical principles. That concludes the station. You've passed. So, stepping out of the exam room for a second, what's the single biggest takeaway from all of this? It really boils down to this one quote. Every single decision you make when managing a fistula, from the very first exam to picking the right operation, has to be laser-focused on preserving the patient's continence. That right there is the ultimate measure of a successful outcome. And that really brings us to a much bigger question, doesn't it? We live in an age of incredible surgical technology that's always evolving. So how do we make sure that all these shiny new tools and techniques are always guided by those timeless fundamental principles of patient safety and care? Because the real art of being a great surgeon isn't just about mastering the latest gadget, it's about having the wisdom to know when to use it, and, more importantly, when not to.